Test, test. I think that sounds pretty good, hey? Now I'm going to try and set up a second camera for you guys here. But what I'm trying to do tonight is create an environment for you all to experience some tutoring that we do on a fairly regular basis. By regular basis, I mean that we do this every couple days. We do this on Sunday nights. We do this on Wednesdays. We also have live classes on Mondays and Fridays, as you probably already know. And what I want to do tonight is give you an opportunity to witness what we do here within Mastermedics as far as a tutoring opportunity. And so here's kind of just that opportunity to kind of see that. Now, I'm just setting up a couple things in order to kind of give you the best experience I can with a couple extra cameras and so on and so forth in order to kind of give you a pretty cool experience. And I'm just working on that right now. So while you're waiting, why don't you let me know what you guys want to hear tonight? What are you interested in seeing and learning tonight? And I will make that happen. Go ahead, put that in the comments, and we'll get started in a moment here. We will go over RSI. Will we go over RSI? We certainly can in a broad sense. Yeah. Yeah, we certainly will. I have an idea. If you hear me rustling in the background, I apologize. I was trying to get something set up for you, and it had it working in this afternoon, and then all of a sudden, of course, as things go, stopped working for me. But I have an idea that I think will do the trick. So bear with me. So what about RSI do you want to learn, I guess, is my next question too. Is there anything specific that you want to learn about RSI, or just RSI in general is what you want to talk about? All right, now let's see if I can do this. Simple BVM setup with Capno, King tube setup and fill. I don't have any King tubes with me. We can talk about SGIs for sure. We will be going over endotracheal intubation and other advanced airway procedures. We certainly can. And so this all comes down to you give me ideas and I will make it happen. How about that? All right. I think I got an idea for you that I think you'll be excited about. Check that out. All right, let's make this interactive, hey? Okay, so yeah, we absolutely can. I've got all of my equipment here. Talking about capnography, I can switch back and forth between the board and this guy right here. So, what do you guys got for me? Capnography. I want to kind of take RSI. Just starting paramedic school, would like to get a head start on RSI. Okay. I would like to really kind of focus on RSI a little bit later because I think RSI is a very advanced thing, which is fine. My concern with it would be is that we're skipping things that need to be discussed prior to ISI. So what are some questions that aren't really RSI per se yet? And then we'll kind of wake our way into RSI. Okay, so one question that that came up to that was mentioned to me a few days ago was the concept of oxygenation and ventilation. And so by that I mean is what's the true difference between the two? Like, is there does one go with one or one go with the other, and so on and so forth? And the answer to that is that when it comes to oxygen and ventilation, they can be both correlated or they can be separate. So there is a difference between oxygenation failure and ventilation failure. So what the difference would be, I'll give you a better color than that. So these are two alveoli. Okay, so you have two different failures. You have what we call a hypercapnic failure, hypercap, and then we have a hypoxic failure. Okay, so we have two different types of failures. And the difference between the two, hypercapnic being here, hypercapnic would mean that we have a failure of moving air in and out of the alveoli. Okay, in and out of the alveoli. And then with hypoxic, and hypercapnic, that's what gives you your hypercapnia. That gives you your inability to ventilate. And your minute volume is poor, you can't move air, so you accumulate CO2. That's a hypercapnic failure. An oxygenation failure, on the other hand, or a hypoxic failure, on the other hand, is when we have a problem, as opposed to with the bronchioles and moving air, we have a problem with the alveoli and an inability for oxygen to get from one spot into the blood. So that's the difference between the two. We have hypercapnic failure. That's a problem with ventilation, often to do more with the bronchioles and the muscles that are allowing for ventilation to occur. Whereas hypoxic is more to do with the fact that we are having trouble getting oxygen from here in the alveoli to here. So the main reasons that we see hypercapnic failure would be things like chronic bronchitis, CHF. CHF can be a little bit of both. Areas asthma, anaphylaxis, and things that are impeding ventilation, foreign body obstructions, airway burns. These are things that impede ventilation that ultimately result in a hypoxic problem. Whereas we have a hypoxic issue where we have alveolar problems, patients that have pulmonary edema, patients that have pneumonias, like really bad septic pneumonias, patients that have ARDS or acute respiratory distress syndrome. These are patients that have impedance or problems with the alveoli. And that means that we have problems moving oxygen from here to here. That's the difference between the two. Now, I wanted to start there because I think it's important to make this distinction. And the reason I think it's important to make this distinction is because it makes a difference on what we're going to do from a treatment standpoint. So, for example, if you had a patient that had a ventilation problem, let's take a COPD patient. What is one of the first line treatments for a COPD patient? First line med treatment. You'd like to see intubation from start to finish? I'll try, but keep in mind, I'm one person. And typically I do that with two. But I'll give it a shot. So Tony's thinking albuterol. That's right. And so albuterol, in its sense, is that correcting the ventilation problem, or is it correcting an oxygenation problem? It's correcting a ventilation problem. It's causing bronchodilation, which is improving ventilation. So that's a ventilation problem that we're correcting with COPD, and we have a hypercapnic problem that's going to occur with COPD. Whereas a patient that has pulmonary edema, what's our first line treatment with someone that has a cardiogenic pulmonary edema? Is it albuterol? No. It is things like nitro or things like CPAP, because what we're trying to treat is the alveolar problem, the fluid filling up the alveoli. So understanding the difference between a patient that's going to be in a hypoxic failure and a hypercapnic failure can really help you identify what treatment line you're going to go down, because it's going to help you identify, okay, is my problem the alveoli, or is my problem the bronchioles or moving air? And if you can identify that problem, thinking about the pathophysiology, it makes treatment make more sense as to why we go down that path. Does that make sense? Okay. Welcome everyone on Instagram. I kind of brought you guys into in the fold a little bit late, but I wanted you to kind of be here so you can kind of see what we do here as well. And yeah, you know what? What the heck? Why don't we bring in the TikTokers as well? One sec. Let me bring those guys in here so they can learn some stuff too. Why not, right? All right, there we go. Bring everyone into the fold. Why not, right? Okay, so that is to do with oxygenation and ventilation and some of the different types of failure. Now, let's talk about the BVM itself. Okay, so I'm just going to switch stages here. You already know where I'm going with this. Okay, so let's talk about some of the treatments. So let's start with oxygenation, then we'll kind of make our way there. So think of it this way, is that I have a ventilation patient. Okay, I have a patient that has a ventilation problem. And I'm going, okay, I need to treat this issue. Okay, I need to treat this issue. If I put on a nasal cannula or I put on a non-rebreather on a patient that has a ventilation problem, moving air problem, is that really going to improve any of my issues? Go ahead and put that in the comments. This kind of goes back to what we just talked about when it comes to hypercapnic and hyperventilation problems or oxygenation problems. Would putting oxygen on a patient that has a moving air problem really benefit them? Assuming that I didn't do any treatment. Let's say there's a COPD patient. We didn't give them any albuterol. We didn't give them any ipratropium bromide. We've done nothing but put oxygen on this patient that has having trouble moving air. How much of a benefit is that going to have on a patient? Very little. Okay, it's going to have very little ability to move air. And so when we're thinking about these issues with hypercapnia and ventilation problems and oxygenation problems, we need to think about the treatments that we're doing. I don't have an issue putting oxygen on a ventilation per patient as long as I understand that I need to perform more treatments in order for that oxygen to make it down to the lungs. Because if I don't do that, then I'm kind of not really helping my patient at all. So again, there's other things to think about when it comes to how we're going to help these patients. Okay, so is oxygen always the answer? No. Should you put it on patients that are in respiratory distress? Absolutely. But the point of the matter is that if you understand if your patient has an oxygenation issue or your patient has a hypercapnic issue or ventilation issue, is going to be the make or break whether that treatment is going to be a beneficial thing for that patient. So those are the things that I want you to remember. He needs positive pressure. Exactly. Okay. So our patient needs positive pressure. So let's talk about this BVM. First off, an end-tidal CO2 monitor, huge benefit. There's some talk about it being not great up here. It will work as long as you get a good seal for the inhalation and exhalation points of ventilation. Okay, so when you ventilate a patient, and now I'm dramatically squeezing this bag. Okay, just keep in mind this is not how I actually squeeze a BVM. But if I simply, if I get a good seal during ventilation, but then I relax during exhalation, then during that exhalation phase, some of that air is going to escape out the side here, which means that this monitor that's trying to read the CO2 is not going to get a great reading. So in order to get a good CO2 reading, I need to maintain a good seal. So, and that includes during the exhalation phases. So when I squeeze the bag, again, I'm squeezing way more than I should, just to give it a point. I want to maintain a seal the entire time. If you want to try and get a better idea of what's happening as far as an exhalation is for end-tidal CO2, you could put a nasal cannula end-tidal CO2 underneath your mask if this one is failing on you. That is a possibility as well. And that will also give you an EtCO2 reading underneath the mask as opposed to up here. Okay, so always try and use an end-tidal CO2 when we are using a BVM. Now, if this is kind of your first little introduction to EtCO2, I'll give you a quick little rundown of how it all works. I'm going to point you guys back up so you can see. Okay, EtCO2, okay, or end-tidal CO2, okay, is a unit that we use in order to identify, in some cases, in this particular case that I'm talking about, is ventilation. So a normal EtCO2 is identified as between 35 and 45 millimeters of mercury. Which that means is that there is between this number, if it is between this number, when you see it on your monitor, you're going to see a value of concentration is essentially what this is. And it is controlled by your minute volume. Not just your how fast you're breathing or how slow you're breathing, but your minute volume. And so your minute volume is your respiratory rate times your tidal volume. Your tidal volume, I'll get out of the way so it actually comes up. Your tidal volume is the amount you're breathing per breath. So for testing purposes, What's the amount that typically we're breathing per breath? Just kind of in a ballpark. Go ahead and put that in the comments. How much do we typically breathe per breath? What do you guys think? Well, yeah, 16 breaths, but yeah, roughly between, let's say, yeah, Tony's kind of on the right track. Between 300 to 500, depending on how tall you are, you're going to be roughly about 300 to 500 breaths, maybe a little bit more if you're like Shaq size, right? So your tidal volume, let's say your respiratory rate is, let's say 12 times, 500. Okay, that is how much, right? I mean, that's going to be, my math isn't fantastic without a calculator, but that's what, 6,000 mils, if I'm doing the math right. Okay, and so 6,000 mils should be able to maintain a CO2 between 35 and 45. Okay, so if, let's say, we are declining, so in a COPD patient, we're probably going to have a less than ideal tidal volume. Okay, we're not going to be able to move nearly as much air. That's why the respiratory rate goes up. So let's say that the tidal volume now is, say, 4,000. Okay, that means that they're not breathing nearly as much. Well, this CO2 number is going to rise with that. And the reason being is because we rely on that minute volume to get rid of CO2. The higher that minute volume goes, the more efficient we are at getting rid of CO2. The lower that CO2 number goes, it means that we are not nearly as efficient. So the lower that the lower that minute volume goes to the 4,000, below our normal ideal average tidal volume, we're not nearly as good at getting rid of CO2. So what does our blood do? It holds on to it because it can't be breathed out. So that's a little bit about end tidal CO2. And I know it was a little bit of crash course, but I know for those of you that are not members of Master Medics, we have a full course breaking down the physiology of CO2 and understanding the nuances of it, including an interactive scenario when it comes to multiple different types of scenarios of patients with end tidal CO2 problems and how to correct them. And so if you want a really in-depth understanding of EtCO2, I highly recommend becoming a Master Medics member. And that was a total plug, but you know what I'm saying, okay? Because I'm going over very general terms here, assuming that you know a little bit about it. So that's EtCO2. Now, let's go back to this BVM. If your EtCO2 is high, what do you need to do when bagging? If your end tidal CO2 is high, okay, let's say it's at 55, okay, we know that higher tidal volumes, higher minute volumes will get rid of CO2. So knowing that in part, what should we do? The higher the tidal volume, the more I can get rid of the CO2. So what should we do with the BVM? If we have too high of a CO2 and we want to bring it down into regular ranges, we know that increasing minute volume will get rid of it. We'll get rid of CO2. So what should we do with our BVM? We would increase respirations, correct. Some people are like, well, what could we increase tidal volume? Yes, but it's very difficult to do with a BVM, especially when there's no numeric value of minute of volume. Could we do it on a ventilator? Sure. But even with a ventilator, we would increase the respiratory rate before we try and tweak the minute volume, because we could have a bigger impact on CO2 changes and depleting it with a volume change, with a respiratory rate change over a volume change. So the same thing applies for when you have BVM. How do I get rid of CO2? I increase my respiratory rate. I don't increase my volume, I increase my rate. If my CO2 starts to deplete below 35, what would that mean? What would that mean if my CO2 was below 35 and I'm using a BVM? You want to slow it down. You guys are under that, adrenergic response. You're panicking, you're breathing. You're like, I got this. And then you realize that your CO2 is 32 and you're like, oh, I'm going a little too hard on this. You take a breath and slow her down. It means that you're breathing too fast for them. Correct. You got it. Or too much volume. That's a possibility as well, but most likely breathing too fast. Exactly. Okay. Any questions pertaining to CO2 and using a BVM before I switch to a demo? Did I miss anything? If I missed anything above, remember, I'm streaming on multiple platforms here, so I'm trying to bounce around. So if I missed your question, please rewrite it so I can see it. I think you're talking about hypoxic drive. My answer to that would be is that hypoxic drive is not something in EMS that we really are particularly concerned about. The thought process with it is that our body is controlling ourselves when we're in a emphysemic state or a COPD state. They start to enjoy a higher CO2 and start to focus more on oxygen concentrations in order to control the respiratory rate. Does it occur in the emergency setting? Not really. So in CPAP, COPD patients, if your patient is in respiratory distress, we treat it. Okay. There was some talk about don't treat it because they might go into a hypoxic drive. Very, very limited information with that. And so the answer is if your patient is in respiratory distress, if your COPD patient is in respiratory distress, you treat it. You treat it. Okay. I will be talking about Pete. Okay. Let's flip over. I'm going to move this guy up a bit so you can all see. I'll point you guys down. You all can see. Good, good, good. Turn you a little bit so you can see what's up. Okay. Let's talk about this BVM. So a bag valve mask, I'm just going to get rid of the CO2 just because it's kind of in the way. But when I'm using a BVM, I'm using a CO2. I just want to get it out of the way so that way I'm not tripping over it because I'm not hooking it up to anything. Okay. So using BVM, slide down a touch here. Okay. When it comes to using a BVM, the biggest thing that you want to make sure, or some of the big things that you want to make sure, is a seal is a key piece to all of this. Okay. So when you're using a BVM, the typical route would be to use an EC or CE clamp like so around the mask and have your hands. I'll put it on this side as well so you can see it. So C around the mask and 3 underneath the jaw in order to pull the jaw up and give it a good sniffing position or head tilt chin lift like so. So that way you can BVM. Now you would probably put an OPA pin or an MPA into this patient as well. Okay, mine are upstairs. And so we're going to pretend that we have that. Okay, but that's typically how you're going to seal or get a good seal. Now, there really is only one answer. If you have a poor seal and you can't maintain with one hand, what's the correct maneuver to do in that case? If you're unable to maintain a seal and get good ventilation with one hand, what should you do? What do you think you should do? Any takers? The answer is that if you're not able to maintain ventilations with one hand, you use two hands. Okay? If you're not able to maintain your airway with one hand, you use two hands to make the seal and you get your partner to ventilate for you. Okay? So that's the answer. Now, okay, so when we're ventilating, now remember, this BVM, this ambu bag, has about 1,200 mils. Okay? 1,200 mils in this bag. Now, recall back earlier in the tutoring session, how much air do we typically breathe per breath? 550 max. It's more like 350 to 500 is kind of your range. So this bag itself, if I was to squeeze this entire thing, is three times the amount that we should be breathing. So you should never be squeezing this bag with two hands. You want to squeeze it with one hand and truly a third of it. And the best way to determine if you're getting a good breath in are two things. One, your CO2, and two, chest rise. Simple. Okay? So CO2 and chest rise when you're using basic BVM skills. So hold a seal, if you can, with one hand, and squeeze. That breath should be over 1 second. And then relax for 5 to 6. Breath. Breath. Like so. Okay? That is using a BVM properly in order to maintain good ventilations in a basic airway. Okay? So, let's talk about this little funny thing that's at the end of my BVM. Anyone know what that is? Go ahead and put it in the comments. What's this funny thing? Anyone want to take a guess at it? Correct. That there is a PEEP valve. A PEEP valve is what's going to maintain your airway or your alveoli open for a state of time during expiration. Okay, so when it comes to PEEP, typically we start at 5. I'm going to see if this works. Let's see here. Is that backwards? No, you can see that. Okay, 5 centimeters of water. Now, I'm going to give you a good idea of what this looks like and why it's so important. Okay, I'm going to exaggerate my breaths just for a second, just so I can blow up these lungs. And I'm going to turn up my PEEP just so you can see. Okay, I'm turning up to 15 just so you can see. And I got a leak in my bag. Now, you can hear it going off. Now, look at the lungs. Look at how full they are. And look at, I'm going to just stop. Okay, and they nice and slowly deflate. Okay, watch what happens when I do the same thing without a PEEP valve. Look at how much faster they deflate. Okay, this is what a PEEP valve does, is it maintains your pressure inside your lungs. So think of it this way. Whoop. Is that we're going to go with your alveoli again. Okay, these are your alveoli. You have an inspiratory, and then you have an expiratory pressure. Okay, you have an inspiratory and an expiratory pressure. Your inspiratory pressure is going to expand your alveoli out. Typically, if I was to put this patient on a ventilator, typically our peak pressure, our peak inspiratory pressure would be below 30, okay? Below 30 centimeters of water. During expiration, in a patient that has pathology where they're not able to breathe, their expiratory pressures that keep the alveoli open are pretty close to zero. And so even when we don't have a PEEP valve on our BVM, our PEEP or our expiratory pressures at the end of expiration is zero. Now, what happens when you have pathology, like you have COPD, you have something that's not allowing you to maintain your alveoli open normally, is that what happens is that your alveoli ultimately collapse. Okay, so whenever I use a BVM and I relax and I'm in an expiratory phase and I'm not using a BVM, this is the return state that your alveoli will end up in, collapsed, which is not ideal. So by introducing 5 centimeters of PEEP, which is a normal, introductory amount of pressure, keeps alveoli open and expanded even during the expiratory phases. So it keeps some air in there. This is what PEEP does. So is PEEP an important tool to have on your BVM? Absolutely. It should be on every BVM, every single one. And it should be a basic skill to just simply maintain 5 centimeters of PEEP. Okay? Now, I did mention that there is increases of PEEP. And there is. So what does increases of PEEP do? What increases of PEEP do is that you have epithelial tissue that lines your alveoli like so. Okay. As a general rule, the more we expand epithelial tissue, the easier it is for oxygen to get through it, because that's where oxygen needs to go through. It needs to go through the epithelial tissue. So the more we expand the epithelial tissue, the easier it is for oxygen to make it through into the blood. And the more we can get through. It's like opening a bigger door into the bus. So we can get more in at a very short amount of time. So having more pressure during that expiratory phase gives more opportunity for oxygen to get on the bus and get oxygenating the red blood cells. So that's why we would increase oxygenation. Now you might ask, is there a negative to PEEP? Can't I just continue to increase PEEP more and more to give myself more and more oxygenation? The answer to that, unfortunately, is no. You can't. And the reason being, I'm just going to turn this all the way up here. The reason being is that the more I turn up my PEEP, the more expanded I keep my lungs, which ends up increasing something called your introthoracic pressures. I have a hard time saying that word, introthoracic pressures. So inside your alveoli or inside your lungs, you know that your lungs are encased in in the pleural space. So this essentially is where pressure is generating. Okay, pressure is generating in this space. So the more I expand alveoli, the more room I take up, which means my intrathecatic pressures are rising. The reason that's a problem is because the more I increase the pressure in this area, the more pressure I put on the superior and inferior vena cavas of the heart. And the more pressure or tamponade I put on those, the less I can fill the right ventricle with blood. So in other words, the more I increase PEEP, the more risk I run decreasing preload of the heart, thus cardiac output. So whenever you're using a PEEP valve, and whenever you're increasing PEEP, you should be running blood pressures every single change that you make to make sure that you're not having adverse events while increasing PEEP. PEEP is a great tool. Unfortunately, it has adverse events like every other tool that we own. So that is a little crash course on PEEP. So how would you know to use it, or how would you know to turn it up? The answer to that would be you're going to be trending it against your vital signs, particularly your SpO2, because we know that PEEP is going to have an improvement on oxygenation. And so let's say if I intubated this patient or ventilating this patient and I have a saturation of 86% and I'm at a 5 of PEEP and I have good ventilation, I got good chest rise, I got a good end tidal CO2. What I don't have is good saturations. Let's increase the PEEP to 7.5, run a blood pressure, reevaluate the SpO2 in 3 minutes. How am I doing in the saturation? Okay, we're at 88%. Okay, my blood pressure is still good. Let's increase the PEEP to 10. Let's continue to ventilate. Reevaluate, run a blood pressure. Make sure the blood pressure is still not hypotensive. They're not good. What's my SpO2? Oh, it's 91%. Okay, so we're trending in the right direction with 10 of PEEP. Let's maintain 10 of PEEP and reevaluate in 4 minutes or in 3 minutes or 5 minutes and see where we're at. We're at 93, 94%. Perfect. We're going to stay there so that way we continue to oxygenate properly. So basically, increasing PEEP is all about trending your vital signs and making sure we have no risk or low risk for that matter. That's how you trend a PEEP. Would PEEP help with a CHF exacerbation where the patient isn't alert enough for CPAP? Yeah, it could be if they could tolerate a BVM. How does that work? Well, CPAP gives you, I'm going to draw the alveoli once again. You have your inspiratory. You have your expiratory. Okay. CPAP is in its name exactly what it does. It delivers a continuous rush of air regardless of the phase of ventilation you're in. So whether you're inspiratory, you're in your inspiratory phase, you're in your expiratory phase, it's delivering a constant amount of air. So CPAP in itself will increase your inspiratory pressure, but it also at the same time will increase your inspiratory and your expiratory pressures. So CPAP, when you're using it on a patient that has COP or CHF, is increasing both inspiratory pressures and expiratory pressures. If you have a patient that is not able to tolerate a CPAP because they're altered or so on and so forth, they're hypoxic, they're altered, and then you go to a BVM and you go, okay, should I be using PEEP? The answer is check a blood pressure, make sure that they are not hypotensive. And if you don't have any contraindications with PEEP and the risks are low, then yes, increasing PEEP could help benefit increasing the expiratory pressures, thus hopefully improving oxygenation and returning this patient from an altered state. So could PEEP help? Yes, as long as there's no risk or there's a low risk value, meaning that they are not hypotensive yet, which they may be. If they're altered, they're hypoxic, there's a good chance that they are also hypotensive, right? So it just depends on where your patient's at on their journey here. Could you use PEEP in intracranial or high intracranial pressure patients? Again, their issue in ICP is not oxygenation. It's just not. So is there a real need to go to high levels of PEEP? No. They don't need PEEP. What they need is good ventilation, probably with 5 centimeters of PEEP, maybe a little bit more, but not much. They don't need higher levels of PEEP. Is it a benefit? It would depend if they have any underlying pathology. But in a straight head injury, increased ICP patient, there's really no benefit to increased PEEP. Okay. Does increasing PEEP decrease the need to produce need or production of surfactant? No. So the question is, does increasing PEEP decrease the amount of surfactant that you produce? The answer is, I don't think they don't really have a correlation between them, other than the fact that, let's say you have a surfactant washout. For example, in the Friday case that we did a patient that had a drowning incident. We had a pediatric drowning. They had ingested or aspirated a lot of water, and they had surfactant washout. And that surfactant washout, when you have surfactant, what surfactant essentially does, it creates surface tension. So surfactant is found in your lungs, okay, and it allows for good surface tension. So it kind of coats your alveoli like so, and keeps them open, and keeps them a good surface tension, and keeps them open like so. So when you have surfactant washout, what occurs is what we call atelectasis, and atelectasis is the collapsing of these alveoli, because the washout of surfactant means that we have decreased surface tension, and it just collapses like a flat ball. And so what PEEP does in those situations is that it kind of replaces what surfactant's supposed to do, and it's supposed to keep good expiratory pressures and snap those alveoli open and prevent the collapse of them, prevent the atelectasis. Good question. How do you, this is a great question. How do you decide whether you need to increase PEEP or increase FiO2 on oxygenation? So we haven't really talked about what FiO2 is yet today. What FiO2 is, FiO2 is your fraction of oxygen. So for example, it's all based on a percentage. You and I are breathing in probably 21% oxygen. So that in fraction of oxygen terms, that would be 0.21%. Okay, our 0.21 fraction of oxygen. In a BVM, when you are hooking it up to a reservoir, you're giving 15 liters per minute and filling up this reservoir, you are giving a fraction of 1, okay, 100%. In other words, 100% oxygen. And so the question that is that's being asked is more of an advanced or critical care question, is when do you know that you should increase PEEP or increase FiO2? Because on a ventilator, we can control the amount of blend of oxygen we give them as opposed to just increasing PEEP. And the answer to that is it depends. I typically start with my PEEP, and then from there, I will start to increase my oxygen supply. And so basically what I talked about when it comes to how I increase PEEP is I increase it, check blood pressure, increase, check my risk, increase, check my risk. If I start getting to the point where my risk is too high to increase PEEP further, or I'm now into the point where I've got high inspiratory pressures or plateau pressures, this is again critical care stuff. If I'm getting to the point where my risk is too high to increase PEEP further, then I start increasing my FiO2. That's kind of how I play it. And again, it's patient dependent, but as a general rule, I typically will target PEEP to improve oxygenation, and then I will target the oxygenation side of things. And why do I do that? Because it doesn't matter how much fraction of oxygen I give if my alveolar exchange sucks, right? It doesn't matter if I give 21% oxygen into those alveoli, or if I give 100% alveoli or oxygenation if my alveoli look like that, right? That's why. So increase PEEP, get good alveoli, get them out of that state, and then your increases of fraction of oxygen will have a better improvement. So that's typically how I focus on that. Can I do some vent training videos with a Revel vent? I don't use a Revel vent. I use the Hamilton. So I can't really speak on the Revel. I can speak from a ventilators in general terms, not tonight, because that's something that you have to kind of start at a very ground level and work your way up. Can I speak on the Revel? No, I don't know the Revel. And so I honestly, I can't get into it, obviously, if I don't know it, but I can speak specifically on the Hamilton. I can speak on the Oxyolog, and I can speak on general terms on how to use a ventilator at a later time for sure. If your patient is located at high altitude and they're having respiratory distress, the best answer for that patient is yes, CPAP will help oxygenation because it will prevent HAPE or high altitude pulmonary edemas. But the best answer to high altitude emergencies is a lower altitude. Okay. Mike, it's good to see you. How do we know when PEEP is working? Man, we could talk about PEEP all night, hey? So how do we know when PEEP is working? The answer to that question is that you're going to use your oxygenation status, your SpO2, in order to determine if your PEEP is working. So take a baseline prior to using PEEP. Okay, my patient is at 84% saturation. I start using a BVM with 5 centimeters of water per PEEP, and I notice that after 10 minutes, I reevaluate and my SpO2 is now 89. That would suggest that your ventilations with PEEP has improved the oxygenation status. You go, you know what? I want something better than 89. My blood pressure is good. Let's increase to 7.5. Reevaluate in 4 minutes, check the blood pressure, confirm that you're not hypotensive. And yes, my SpO2 is now 93%. Boom. That's how you generally are going to use PEEP in order to determine if it's working. Okay. Keep in mind that if you are not intubating your patient, okay, that means if I'm using a BVM with a PEEP valve with a mask, and if I want to do this properly, again, I'm going to just blow up the lungs so you can see them. If I want to do this properly, I need to make sure that I'm maintaining this seal this entire time. Because if I lose my seal, I lose my pressure. So it's all based off how good of a seal you have. So if you're using PEEP, I highly recommend using a two-handed seal, or if you get a leak, you're losing all your pressure. So PEEP valves do have their negatives in the fact that if you're using it with a mask, you will lose your PEEP if you lose your seal. So two-handed seals are important for that. Straps for BVM, sure, that'll work. I don't want to get too much into hemorrhagic stroke, Samantha, just because I want to kind of stay on the same track, if that's okay. You can certainly ask your questions or shoot them in a message. I'm only going to do another 30 minutes of like open session, and we can certainly ask that when we close the session to just members. Okay. Any other questions on PEEP? Just checking to see if you're good. Yeah. When they're needing ventilation, you're not happy with the SpO2, PEEP would be a big benefit to these patients. Will I be doing any live cardiology classes? Perhaps in the next little bit. We do tutoring sessions. So what you're seeing or what you're witnessing here is actually a tutoring session that I decided to make open. We do these twice a week with our members, and they guide our tutoring sessions. What I decided to do tonight is give you a taste of what we do in those tutoring sessions. We kind of talk about how things work, and we get questions, and those questions kind of guide how our stuff goes. So I just decided to open it live for everyone tonight so you guys can kind of see what that is. But do I go over cardiology stuff? If you guys ask me to in an open tutoring session as a member, absolutely we do, 100%. Tonight, we're kind of just focusing more solely on airway and oxygenation stuff. And then we're going to really get into basically a closed tutoring session with just our members after we finish this up. But yeah. Chris is awesome. I do love Chris. So Chris Hollett's one of our instructors that does a lot of the tutoring sessions. And yeah, so I'm good. I'm glad that you like Chris. All right, I need a drink before I can continue. Okay. I think we're good. I think we're good on PEEP. Hey, I don't think I saw any more questions about PEEP. We can certainly help you with cardiology, Mariah. We do. We have a lot of cardiology classes on the Master Medics membership. So if you are interested, you can check it out for a free trial. You just hit the link in our bios, check it out for 3 days, check out the cardiology. If it solves your problem, stay as long as you like. If it doesn't, you can cancel. And you don't pay a dime if you do it within the first 3 days. And so yeah, check out your cardiology stuff there. I think it'll really help. And you can kind of see how we teach. It's very similar to what I do now. It's very hands-on, very visual. Okay, so let's start talking a little bit about more intubation stuff. I'm just getting my stuff ready here. Grab my blades. Okay. So what questions, I'm going to do some intubation stuff. So what questions do you have when it comes to intubation? Go ahead and put those in the comments, even though I just posted a video about using 4 blades. And instead of 3 blades, I prefer 4 blades, so I'm going to use a 4 blade. But we can talk about blade changes. I'm going to grab my trusty VL as well. I didn't lube this guy, so hopefully he's doing okay. Okay, and of course, grab the stethoscope. Okay, so what questions do you have about RSI? When COVID hit, a lot of doctors were using high PEEP. You know why? Because, where did I put my, oh no, I lost my marker. The reason that they were doing high PEEP is because in COVID, the issues in COVID were alveolar problems. They essentially developed, in essence, an ARDS, an acute respiratory distress syndrome. And ARDS predominantly studies focused on an oxygenation issue. And so what we've done with COVID patients is we've kind of put them in that same category of how we treat these in a critical care setting. And yeah, we use a lot of PEEP in order to keep those alveoli open. And yeah, I've seen patients with a lot of PEEP with COVID, a lot of PEEP. And it worked. And that was all to improve the oxygenation issue that we knew that was happening. So yeah, we did see a lot of PEEP, high amounts of PEEP. Why is propofol the go-to? Is it because it's fat soluble and it crosses the blood-brain barrier easier, or does it go through diffusion, or does it use as a catalyst? That's a good question, Simon. I see your question too, Seth. So I'm going to just throw that up there. So why is propofol the go-to? My answer to that is, in EMS, I don't think propofol truly is. Why do physicians and why do anesthesiologists choose it? I think it's because it's short-acting, it's easy to calculate, and it's easy to run in a pump. I use pretty minimal amounts of propofol personally. We have access to it, but I don't use it very often. I typically using a lot of ketamine and a lot of ketamine. So I guess the answer to that question is that I can't really speak for why anesthesiologists tend to love it. I personally don't use it a ton. I have used it and I don't mind it. It's just not in my regular repertoire. Ketamine typically is my go-to choice. So how do you pick your tube size? So for an adult, I typically go for a 7.5, which I have in my hand here. Okay, adult male 7.5, adult female 7. Okay, pediatrics a little bit different. If you guys saw my post a couple days ago, it was on pediatric intubation and choosing the tube for your pediatric. And it was, in order to determine that, it's age divided by 4 plus 3.5. That's determine your tube, your cuffed tube. So for example, if your age, if there's 6, divide that in 3 is 1.5, or sorry, divide that in 4 is 1.5. 1.5 plus 3.5 would mean that you are doing a 5 tube. So that's how you determine pediatric tube sizes, is using this equation, age divided by 4 plus 3.5. It's the Durature formula. Okay. Great question, because it's always something that comes up. Best way to position for difficult airway. In my opinion, in most airways, I think we should be in a ramped position. What a ramped position is that if I was to draw it on here, I'll come back to that in case you guys are still writing it down. A ramped position, if this is your stretcher, okay, you want to put them in a low Fowler's stretcher position, okay? Then you want to pack blankets like so beneath the back to get them kind of up like this. But if you do that, then the head kind of flops backwards. So you kind of need the head on a little bit of a pedestal that's slightly above, basically taking the earlobes and making them just above the shoulder blades, the anterior portions of the shoulders, like so. And if you have the head up like so, and the body kind of in that position, it kind of rests them almost in like a sniffing position, but the head's kind of like the chin is like tucked out. And by doing that, it allows for a better position in the ambulance. I just did a video today actually on Instagram talking about this position, so definitely check that out. So in my opinion, that position, as poorly as that is drawn, is the position I put them in. If you want a better representation of it, I did it with our mannequin today in the ambulance. So go check that out on Facebook or Instagram or YouTube or TikTok. You will find it. Okay, so that's the best way to position for difficult airway. Okay, so here's another question. Do you always use a bougie? Yes, I do. I do use a bougie almost every single time. Pretty much every single time. I can't think of the last intubation I've done without one. Here's the reason why. I intubate a decent amount, but not enough for me to say I don't need one. Because I feel a lot more comfortable with my skills when I use one. And when I practice, I use one all the time. And so my thought process with that is that if I'm practicing with one on a regular basis, then I should be using it with all patients. Do I necessarily need it with all patients? Maybe not. Am I more confident that I will make that tube most of the time, literally 95% of the time if I use a bougie? Yes. So why not? And the studies show that using a bougie is better than not using a bougie. Like the evidence is just there. So do I use a bougie? Yes, I do. Okay, I absolutely use a bougie and I use it for most intubations. How do I load it? Okay, ET tube, pull the stylet, load the bougie. I like to have a lot of bougie at the end. And then what I do, it's in the wrong hand, so that I curl it like so. Okay? And that way I have a good grip and I can move around. So I'm going to use a VL. Okay? But if I was to intubate, the next question I'm sure is going to be, what blade do I use if I'm using a direct? I typically use a 4 Mac. Okay, but unfortunately, the evidence that came out that I just read recently and did a video on, unfortunately, it says that my view often is not as good with a 4 as opposed to a 3. And first pass successes are actually less in a 4 than a 3. But my VL is a 4. It's literally the exact same blade. My VL is a 4. Okay. It's not a hyperangulated blade. And I'm just more comfortable with a 4. That being said, the evidence is suggesting that 3 might be better for visualization. I just, I guess, stuck in my ways, and I haven't had an issue. But if you do, maybe that's the case. Okay, so I don't have any lube down here, but we're going to try and prep this intubation. Okay, so what you'll notice is that I have a blanket or a towel underneath the head of my patient. Okay, this is if I'm on a flat surface and I'm intubating in a hospital, this is typically how I'll intubate, is that I'll have a blanket folded up underneath the head, lifting it about 4 inches. Okay, bringing it ahead of the shoulders. Okay, from there, get them into a good sniffing position. And this should give you a good angle on the axis in order to intubate. Now, one thing you won't be able to see very well on camera, but what you don't want to do is you don't want to lean back with your laryngoscope. That's a great way to smash teeth. Okay, so you'll notice that I'm kind of using my wrist to lean back. You don't want to do that. Once you're in position, what you want to do is you actually want to lift up. Okay, do you notice a difference? Instead of using my wrist to lean back, I'm going to lift up. Okay, this gives me the same view. The only difference is I'm not going to break teeth. Okay, so lift up instead of back to get a good view. Okay, bougie, tip up like so. Okay, you can't quite see that on video. And you in place like so. If you're having hard time manipulating the bougie, you can simply turn it and get it in place. I'm getting hung up on the rings, on the vocal cords, sorry. And I can't quite see it there because I'm actually bent my bougie. In place like so. Okay. From here, unhook my tube. In place. I'm getting hung up because I didn't use lube. So that's a good tip. Always put lube on your tube. And it won't go in place, unfortunately, because I didn't use it. Once you do, from there, take your cuff, blow it up, and check with your ETCO2 as one confirmation. Second confirmation, check with the auscultation. If you get good confirmation, secure in place. And that is how you do an intubation. Any questions with that? Wish I used some lube. That would have been a lot easier. things go smoother when you use some lube. I think it might have some down here still. You don't have those on your tubes? What do you mean? How many black lines go past the vocal cords? Well, let's take a look. This one in particular, 1. Okay, but other ones can be different. Just going to throw this tube back in just so we can talk a little bit more about ventilation. I'm a lot more comfortable with VL now, as you can imagine. There we go. Again, do your confirmations, visualization of the tube going through, and of course, auscultation and EtCO2. One thing that I do like to mention, whenever you're securing a tube, always make sure that you're holding onto the tube the entire time. Okay. Now you can get a better idea of what PEEP looks like. Now check this out. Look at how much pressure we lose without PEEP. That's the power of PEEP right there. Okay. Any questions? Can you go over what you use to reduce gastric distension? Oops, I missed a lot. What is the yellow part? The yellow port is your gastric tube, which should be closed. Most tubes don't. This is from an ICU. Okay. Can you go over what to use to reduce gastric distension once you've intubated? In an EMS setting, there's very little things that we could do to reduce gastric distension. We shouldn't have too much if we're properly ventilating our patient with a BVM and the ET tube is in place and it's cuffed. But if you had to, and if you had the opportunity, an OG would be handy. What are the things you should be doing before intubating to prepare a patient? What's the first confirmation for national? I believe for national, it would be lung sounds, then capnography. Or it could be the other way around. Yeah, then cap, then lung sounds, right? Yeah, like visualization, sure. It really depends on the way that the question is worded, but visualization would probably be one of them. But I mean, I've heard a lot of people say, hey, I saw it go through the vocal cords, and then it ended up actually going down the esophagus. So from a national standpoint, it might be visualization through the cords, then capno, then auscultation, because those are all confirmations of it making it through. Cuff volume and pressure. Cuffs typically between around 8 centimeters, okay, or 8 mils will give you enough. As long as you get some good bounce back on that guy, that's all you need. Okay. If it's too hard, you probably got too much pressure in that. You can cause ischemia, especially for if you have a longer one. We actually use a smographer, or it's basically a pressure monitor, and we typically try and keep that monitor under 30. And we do need to check it on a regular basis, because when we go up into higher altitudes, it tends to expand. And so we can get higher pressures of like 50 or 45, and then we'd have to take some of that pressure out. So it can go higher, but typically you want to maintain around 30 or lower. Okay, anything else? No problem. What are the things that you should be doing before intubation? What are the things that you should be doing before intubation? That's a good question. I would say that basically the things to do before intubation is to talk to your team. I'm a big checklist person, so making sure that you go through a checklist with your team to make sure everyone's on the same board, okay, or on the same page. Making sure the team knows. That's the first thing. Next thing is, what else am I going to be doing? I preload my ET tube. I make sure that I have an SGA prepared. So if I do fail this into airway, I can put an SGA in. And then I can either reevaluate and swap it out, or I can leave it in depending on how well it's doing, depending on how it's doing. Let's leave it at that. Basically, what am I doing before I place the airway is that I'm making sure that I have excellent positioning of the patient. I'm pre-oxygenating the patient, and then I'm performing apneic oxygenation by also having nasal cannula and running it during that as well. Those are the things that I'm doing. If you guys really want to see a good breakdown of what I do or what is expected in a good intubation, is actually go to our the course, the airway course that we have at Mastery Medics. I just posted a new video on the step-by-step process of how to intubate. It is in the airway course in the advanced airway section in the paramedic level on our website. Okay, it just went up this afternoon. Brand new one. What ETCO reading would you like to see for a successful tube? I would like to see a, well, depending, like when you put a successful tube in, what you want to really see is a number that's between 35 and 45. You might see a higher level one, especially if you had a longer apneic phase, right? Because you're retaining CO2 during that apneic phase. But what I'm also looking for is waveform, and making sure that I have good waveform with my ventilations, because that's also an indication that we're picking up EtCO2 from the lungs, not elsewhere. You can get EtCO2 from the esophagus. It's like low, and it also doesn't produce good waveforms. But yeah, so what I'm looking for is a within range EtCO2 or high EtCO2 initially, and then also my proper waveform that is corresponding with my BVM. Okay. I don't see anything else on Instagram, so I might sign off on Instagram because I only see a few people still watching. So Instagram, thank you for watching, and we're going to take care for now. And let's take a look at, you guys are still good. Any other questions? This is kind of where I'm at with my talk on ventilation, oxygenation, and intubation. Go ahead and throw some more comments in there. If you need. If not, we can always call her a night. What do you do for shark wave waveform? So a shark wave waveform, what that's pertaining to is EtCO2. And a shark wave waveform looks like this. Literally like a shark fin. Why is that? Well, what happens if these are your bronchioles and this is your alveoli? When you are breathing in and you have CO2, okay, that's sitting here. Now remember, your monitor of CO2 is way up here, right? So when you are breathing, you not only have functional air that you're breathing, the alveolar air is the actual functional air that's going to exchange CO2 and oxygen, right? All of this air is mostly nitrogen. It's atmospheric air. It doesn't exchange CO2 and oxygen. So when you have really, really narrow bronchioles, okay, like so, that means all of this atmospheric air needs to go past this monitor before the CO2 does. So we actually don't get this functional air until the very end of our breath, because it doesn't mix with this air. When our lungs, with the way we're breathing right now, we have good bronchioles. This CO2 mixes with our atmospheric air and gives us more of a nice kind of pattern like that. But with bronchoconstriction in COPD patients, this doesn't occur. We have these really narrow bronchioles, which means all of this atmospheric air comes first, which doesn't have any CO2 in it. That's basically this, okay, this part over here. The CO2 over here finally reaches the sensor after all this atmospheric air, and then we have this dramatic spike of CO2 at the very end. That's why it happens, that shark fin pattern. Now, what do you do with it? This is a classic obstructive pattern, okay? The pathology of why we see it is purely because of the bronchial constriction. So the answer of what should we do in this situation is to correct the bronchial problem. So how do we correct this bronchial problem? Go ahead and put it in the comments. How do we correct a bronchial problem? Any ideas? Give albuterol, right? We give nebulizers. We do MDIs. If this patient's already intubated and we see this this shark fin pattern, we get some MDIs with a spacer and we spray a bunch of MDI, salbutamol or albuterol down that tube. If this patient is not intubated, you can technically use a spacer with a BVM and a mask and start spraying it down there if you are ventilating this patient. But the point is that we need to get as much bronchodilator down this patient as we can in order to bronchodilate, so that way we can fix this problem. Or if you need to, epi. Okay, or magnesium, lots of other options. But the point is that when you see this, this is why it's happening. And so in order to correct this, we need to fix this problem, and that is bronchodilate. Okay. Does that answer your question? I think that came over from all the way from TikTok land. No problem. Okay. What else we got? I don't think we see any more questions. We've covered a lot tonight. It's been overwhelming, I'm sure. So I'll open it up, give you guys a chance to have one last question, and then maybe we'll call it a night there. Because as you can probably imagine, I am also spent. So just for you guys to be aware that we're doing a formal lung lab. I've purchased pig lungs for Wednesday night. So from same time that this live went on Wednesday, it's going to be a closed class for just members. Okay. It also is going to be continuing education approved for Canadian paramedics. So you guys can actually get credit for it coming to the lung lab on Wednesday night. You get 2 hours of lung lab time. So if you guys are interested in that, we're going to actually be doing very similar. We're going to intubate the lung. We're going to talk about PEEP. We're going to talk about ventilation. We're going to talk about intubation and how these things all come together. Talking about tension pneumothorax, we're going to put that lung under pressure and we're going to cause a pneumothorax with it. We're going to do a lot of really fun stuff. That's again Wednesday night at 6 p.m. Central. We're going to do all of that for our members. So if you're not a member yet and you want to check that out, it's going to be a sweet class. If you signed up tonight, you would still be within your 3-day trial Wednesday night. So you would actually get access to that class before your trial is over. So technically, if you signed up today or tomorrow, you would get that class for free as a Master Paramedics member. So if you want to check that out, that is the way to do it. Do we keep these live recordings? These ones in particular, we do not. And what we do, but we splice them up and use them, I guess, is probably that's. We don't have the full recordings available for people, unfortunately. And the reason being is that typically we'll have members come on and sometimes they're in their uniforms. Sometimes we don't have permission to share their faces or their voices. And sometimes personal information is shared in order for us to kind of give guidance. And so we choose not to share these recordings. This one didn't have any issues, but predominantly tutoring sessions we don't. Actual classes we do. Okay. Well, I don't see anything else coming up. Where can you join the private lab tutoring? So it's all super easy to find. When you join in, right on your dashboard is a place that you can look at the live tutoring schedule. And do we get notified? Yes, you do. You get notified of all live sessions 1 hour and 4 hours beforehand. Check it out. I bet you you'll love it, Mariah. I really do think you'll love it. So check it out and see what you think, and then we'll go from there. But I think you'll really enjoy it. The tutoring, honestly, is a small portion of what we offer. There's a huge course library, exam prep, everything you need to know there. Okay, well, I'll leave you at that. Thanks again for joining me tonight. I really, truly appreciate having you all here. And I'm going to sign off now. And again, if you do have questions after the fact, please feel free to reach out to us and ask your questions. We're more than happy to chat. And again, if you're interested in the lung lab, it is on Wednesday night where you can say hi to us and learn about ventilation, tension pneumothoraxes. All of this stuff is all going to be taught with a actual pig lab, pig lung that's going to be sitting right here on this desk. And you're going to get the same view that you got with this mannequin. So that way you get a really physiological understanding of how this all works. So thanks again for joining me tonight, and we'll see you next time. Bye for now. Yeah, that fly was pissing me off. Thanks, Eric. I still haven't been able to catch him.